Hello, I'm Dr. Omar Bey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. Well, another good show here. We're going to do it this time. We'll be talking about the knee and arthritis, and I have the perfect person to talk about that topic. But first, I want to talk about our sharing and caring, because it's so important that we let each other know what our medical problems are so we can talk amongst ourselves, and we can let me know here at the show so that we can have the appropriate programs on so that you can increase your education about your medical conditions. Well, you can email me at www.medmoments.com, and you can tweet me as well at medmoments. Well, let's start our show. We're going to be talking about arthritis and the knee, and I have the perfect person to talk about that subject. His name is Dr. James Lee Jr. He's an orthopedic surgeon. Dr. Lee, welcome to our show.
Thank you, Dr. Bay. Glad to be here.
All righty. So this is the second time we're having you on.
Yes.
The first time we had talked about the hip and osteoporosis,
Right.
all those big words, we had to jump out with them. But this time we're going to talk about the knee, all right, and arthritis and maybe other aspects of the knee as well and what happens to the knee. Now, what I'd like to do is just kind of summarize an orthopedist or orthopedic surgeon. You guys take care of the muscles as well as the skeletal system, right?
Absolutely. Mm-hmm. So we specialize in musculoskeletal care, as you said. Mm-hmm. Muscles, joints, tendons, and ligaments all work together in unison.
Right.
So it's very hard to treat just one part, just bone, just muscle, just a ligament. So when we address these issues, we try to take the whole picture in place, and we look at how somebody walks, the range of motion of the joint, and all of these things are affected by muscles, ligaments, posture, and so we sort of treat the whole picture in this case.
Excellent, excellent. Well, we're going to talk specifically about the knee this time.
Great.
All righty. Now, I understand, put it this way. I know I have knees, and I know they work for me because we stand up and we walk all the time. Right. But give me an understanding on how the knee is put together and how it works for us.
That's a great question. To put it simply, it has three compartments, okay? There's three compartments. There's the inside compartment, the outside compartment, and where the kneecap sits, okay? We think of the knee as a hinge joint, most simply. It bends and extends. So when somebody straightens out their leg, we call that extension. And when they bend it, we call that flexion. We run into issues when people start to lose that range of motion, either from an injury or some type of condition. Right. And when they lose range of motion, we typically evaluate them with an x-ray or a good clinical examination or both to come up with some type of diagnosis.
Okay, so what you're talking about is that the knee it's like this, and it's kind of cruising on itself like this.
Yes.
So it extends and it bends back.
That's right.
Alrighty. So how long should someone, if you're using your knee appropriately, not you know what I mean, running 50,000-mile marathons, but using it appropriately, how long should it last for you? Should it be 40 years, 50 years, 80 years? Should it never have a problem? How long would a knee last usually?
Great question. Everybody's different. Having been in practice for 5 years, I see all shapes and sizes, right. All walks of life. So imagine a gentleman who is a heavy laborer, construction worker, pounding away, walking up and down a construction site, always having to use his knees, versus somebody who is maybe a little lower maintenance, doesn't have a heavy labor job, maybe more in an office. We look at occupation. We look at size, how well proportioned the patient is or the person is.
Right.
Are they large? Are they small? Are they well proportioned from their torso to their legs? I think all of these are factors. Do they have any family history of bone problems or arthritis? Because that can affect things as well. So I think that's an excellent question. There's environmental issues that we're faced with.
Right.
There's family health issues as well. And then there's the health of the patient themselves.
Right.
So to answer your question, I think oftentimes there's not a great answer. I feel that if somebody is in reasonably good shape, good health, they should get, the typical lifespan out of their knees. All joints, unfortunately, do have an expiration date in terms of wear and tear. And there's different degrees. Some people wear it all the way down. Other folks are lucky enough to get in the 80s and 90s.
Right, right. So it's like a car. If I drive it at 100 miles an hour, then guess what? The motor's going to say, hey, I give.
That's right.
All righty. I got you. Let's talk about arthritis now, because that's a big thing as far as when we, I can imagine younger people could have arthritis as well, but just give me an understanding how arthritis how does that play as far as the knee is concerned?
Okay, great. That's a great question. The cartilage, which is the cushion on the inside of the knee, when we're born, it's very smooth, and there's very little friction. It's like, I guess, somebody who's ice skating, just smooth. But as we age and as we run and create these, we call micro-traumatic events, these small little issues, there's fissures that are created. Think about the Grand Canyon. How many millions of years it took to create that big canyon. It started very small with a stream, and then over time it enlarged, it got larger. So the knee joint's the same way. Over time, the fissures in the cartilage get larger and larger.
Now when you say fissures, what do you mean, cracks?
Cracks,
okay.
Exactly, cracks in the cartilage. That leads to inflammation.
All right. And when you say inflammation, you mean swelling?
That means swelling, right. So oftentimes, a patient will come in, it's, my knee is swollen, or I feel like there's water on the knee.
Right.
Those are all things that oftentimes go hand in hand with arthritis. Okay. So when there is that fissuring and that process, it creates pain, swelling, the motion is decreased, and there's a limp, sometimes a need for a cane, and oftentimes it can last for a few days, and sometimes it can last for years.
Okay, all righty. Now, as far as once arthritis is in the knee, can it ever just go away?
Great question. There are irreversible, meaning changes that cannot be changed. Once that cartilage that we talked about, that cushion is gone, it does not grow back, okay? In select patients or people, if there's just one small piece missing, we are able to restore that. However, once it affects the entire joint, unfortunately, oftentimes it's irreversible once that cartilage is gone.
Okay, all right then. Now, I'm just going to get basic with you again. Sure. Now, the two bones sit on each other like this probably, and going like this.
That's right.
You're talking about like a bushing in between those bones.
Right.
That the bones will, so the bones aren't rubbing on each other.
That's correct.
That's the cartilage.
That's the cartilage.
All righty. Now, how does the kneecap come into all of this? Does that get arthritis as well, or that's not a part of the problem when arthritis is
oh yes, that can be. Can be. So the kneecap is almost like a pulley. All right. So the kneecap's purpose is to basically link the thigh muscles with the leg muscles and allow you to extend your knee. And it's almost like a pulley, a fulcrum, if you will, that the knee bends over. That being said, if you walk up and down the stairs, 3 to 5 times your body weight goes across that knee and that patella, or we call it the kneecap.
Right.
I'm 200 pounds, 5 times my body weight is 1,000 pounds of pressure. Every time I go up and down stairs, that's 1,000 pounds of pressure across my kneecap. And over time, as you'd imagine, there can be some changes.
Oh, all right then. Yeah. Well, you had talked about a limp. If somebody's walking with a limp, if I'm walking with if my right knee is swollen and hurting and I'm not taking care of it and I'm limping, will it affect other joints?
Yes, it can. Okay. So one of the things that we look at when somebody has a limp is alignment. So think about a car. There's 4 tires. Imagine if one of those tires is either flat or out of alignment. It will affect the way that car drives and rides. It's the same thing in the body as well. Okay. All right then. Good.
Talk about arthritis. Now, I know there are different types of arthritis. All right. And I know that osteoarthritis is one. That's another big word. Right? Yes. But osteoarthritis is a type of arthritis that occurs in the knee. Can you just give me types of arthritis that may affect the knee?
Sure. You mentioned osteoarthritis. There's also a rheumatoid arthritis. Okay. Rheumatoid arthritis also is an inflammatory condition, but it is one of those conditions where the body affects itself, meaning they can attack the joint with different types of factors that are in the bloodstream. It can end up in the knee joint and actually degrade the cartilage. Okay. There's also gouty arthritis. Okay.
Yeah, I know gout.
Yeah. That's very painful. I can always tell a patient with gout, it affects the knee, the big toe. They'll oftentimes won't even wear a shoe. It's that painful.
Right.
And the knee also can be affected. It's hot, swollen, red, and very, very painful. One other arthritic process is infectious arthritis or septic arthritis. So, you know, unfortunately, when somebody might have a cold or some type of wound, or maybe they're sick, that infection can sometimes get into the joint, and then it can cause a very painful reaction, a lot of swelling, and sometimes even pus, you know, which is very painful. And oftentimes we have to evacuate that out because that infection can that can really degrade that cushion or cartilage in the knee very quickly.
So you actually have to go in surgically and clean that out for the patient.
Absolutely. That's one of those, in orthopedics, one of those emergencies where we, you know, if we don't get to it within a few hours, it really can have some lifetime effects on the joint.
Okay, all right then. Now, I just want to be plain with us because it's the most important aspect of arthritis to the knee. Osteoarthritis is not an infection. Is that kind of wear and tear arthritis? Is that basically what it is?
Yeah, for the most part, absolutely. There are different types of osteoarthritis. Imagine somebody who's in like a bad car accident, or they fell off the side of a building and they jam their legs and their knee gets crushed. That is osteoarthritis, but we would say it's after an injury or post-traumatic, a traumatic event happened. Cartilage was impacted and crushed. And that can happen oftentimes in a younger person, and they have post-traumatic arthritis. Osteoarthritis typically is in the patient population as they age, wear and tear, you know, as you talked about.
Right. Now, is this a very common thing? I mean, I understand that there are like millions of people that have knee problems, and arthritis is a basic aspect. About what age should we start worrying about this thing?
Great question. I think probably in the 50s, 40s and 50s, depending on your level of activity. It's something to pay attention to. Most patients with the osteoarthritis type of condition, the symptoms are stiffness, especially in the morning. And first couple steps can be painful, but what you find is that as the day goes on, they loosen up a little bit. Now we start to worry when they don't loosen up a bit, and that stiffness, pain, sitting up from a chair become very painful and difficult. And that's when we get really concerned.
Okay. I just want to very quickly, because I know that it's so common with these arthritic problems with orthopedists, other areas of the body that may have osteoarthritis. Things like the hands, I think, may have it, or the fingers. What other are the hips? Can the hips be involved as well with osteoarthritis, or are the knees the most common aspect?
Most common would be the knees, but the hips, absolutely. The shoulder joint also as well. In your spine, you know, in your neck, in your lower back, your ankles, and your feet as well. Almost anywhere there's a joint that bears weight or loads, unfortunately, over time it can wear down and cause arthritis.
And you think that because of gravity is pulling us down, the weight and the load of, you know what I mean?
Absolutely, yeah. Gravity, our body weight, all those things play a big role in this.
All righty, good. Now, what about as far as males or females? Is it more prevalent in one or the other?
That's a great question. See it more commonly in men. Not a tremendous difference, but yeah, the male population tends to have done a little bit more of the heavy labor and affects them in that regard. But yes, I would say in men it's more common. Okay, so as far as the joint is concerned, and what's the typical presentation of a patient coming to your office? And you know, you're looking at the patient, examining the patient. How do they present when they have something like this? So oftentimes, I actually like to look at them walk down the hallway, see if they have a cane. So a limp, swelling, and what I like to do is check their range of motion, how far they can extend and flex the knee, and I do a side-to-side comparison, because if the patient says, well, listen, you know, my right knee hurts, my left one feels great, I like to check that one to see if it's maybe normal or you know, less affected than the arthritic side, and really get a baseline range of motion and compare it to the affected side to see if there is a change in their motion, if there is alignment issues, things of that nature.
Okay, all right. Now, what about as far as race? That's a question I wanted to ask you. Particular race do they have more arthritis or more joint pains or knee pains than another race?
No, no. It's in practice and to my knowledge, no. Arthritis typically is an equal opportunity type of condition.
All righty. If you treat this early, do you have a better chance of it getting better, or is it once you get it, it's just going to progress no matter what you do?
I think if you get to it early and you're able to intervene, especially in somebody who's overweight, they can preserve their joint. Patients who have bone-on-bone arthritis who come in that way, we can't reverse those changes. However, if they improve their lifestyle by exercising a little bit more, losing weight, they still can get benefit from not bearing as much load on those arthritic joints.
Okay. Now, there's nothing you can do to help a patient with the cartilage. You say once that cartilage is worn down, we cannot regenerate that cartilage.
We cannot regenerate the cartilage. No. If it's isolated, meaning say it's like a quarter is missing, okay, and the rest of the knee is perfect.
Right.
That particular patient, we can put a plug, if you will, into that area and restore that. However, if there are quarters in the inside compartment, under the kneecap, on the outside compartment, on the leg bone and the femur bone, we don't have a solution for that where we can just fill those in. It doesn't work that way.
Okay.
And in that case, that patient, has irreversible changes. We cannot reverse, what has already happened.
All right then. And when you say you you fill a plug in, is it like strong glue you put in there or something, or how do you fill it in?
Oh, that's a great question. So there's a number of ways. There are actually areas in your knee that are not load bearing, meaning they don't impact against the thigh bone and leg bone.
Right.
Those areas actually can serve as donor sites. We can actually borrow a plug from one area and put it into another. Okay, one that needs it, one that's always under stress from load bearing. Also, there is donor cartilage, okay? There's donor cartilage from deceased individuals that have been cleaned and processed that we can take literally off the shelf and size it and fill in that quarter size or dime size plug, if you will, to help restore that cartilage.
Now, the cartilage that you take from someone else, do you have to worry about the body thinking that it's a foreign object and attacking it?
Yes, but it's very rare. The way it's treated and processed, it essentially eliminates that reaction. I have not seen that happen. It's always a concern, but it is a very rare event that something like that happens.
Okay. I know that they kind of break osteoarthritis down into two different categories: primary osteoarthritis and secondary osteoarthritis. Describe what, like primary, what would that be? It's just like it would happen on its own, or,
Right, that's more of your wear and tear.
Okay.
The joint that is affected usually is isolated in one area. It's usually just a wear and tear phenomenon. Secondary arthritis is usually from some other event, either from a trauma, or there can be a metabolic or condition in the body that can cause some type of arthritic process.
Right. I was reading somewhere that diabetes may have an increased incidence of joint problems or arthritis problems.
Yeah. Unfortunately, in the diabetic population, type 2 specifically, oftentimes it's linked to you being overweight, not exercising, diet can be poor. Those are all contributing factors to overload of a joint, being heavy, and it's definitely linked to arthritis for sure.
So you recommend that your patients that come in that are heavy, first thing you say is, please lose weight.
Yes.
All right, because it saves you. It'll save you from serious problems or maybe surgery in the future.
That's correct. That's correct.
Now talking about surgery, can surgery cause post-surgery, or the improper healing of surgery cause arthritis as well, or cause the knee to be abnormal or a pain?
Yes. Historically, actually, if you go back about 50, 60 years, one of the treatments that was done for knee pain and a torn cartilage was to actually remove it. It was thought that would help things, and they would actually remove the cartilage to see if that would actually aid in healing.
Right.
And what we found is in 10 years, that joint was basically completely arthritic because you know the cushion was removed, and that's where we've evolved. We're now into preservation, and that's a great point.
Okay, all righty. Now, as far as treatment is concerned, if somebody's coming in your office and I understand that probably several things you want to do. You would probably want to decrease the pain and try to give them mobility. How do you start some of this? What do you recommend they do to get their cells back going again and get back to normal?
Great question. The simplest things to do for pain are an anti-inflammatory medication, okay, exercise with a physical therapist, and weight loss. Okay, those are things that are very simple that you can do right away to help impact pain and decrease range of motion. Those are the very first things that we try because they're simple, they're easy. You can try it for a couple weeks and see if it makes a difference.
Does it help most people, or do most people have to go on to that second stage, or maybe a little surgery or something like that? You understand what I'm saying?
Yes.
We all want to try the easiest or the least invasive thing first. Yes. I know, but you are an orthopedic surgeon.
Right, right. Yeah, typically the way we do it is, if somebody is overweight, that's the first thing we try to talk about. Okay. Change your diet, change your lifestyle. If we can do that, you might notice a huge difference. You may not have to see me. Right. If that doesn't really work, minimum about 6 weeks of physical therapy, the anti-inflammatory medication, and giving it some time. If that doesn't work, the next step up on the ladder would be to consider an injection. Okay, we can actually give an anti-inflammatory medication and a little bit of pain medicine into the joint to see if that actually makes a difference. And we try to, we call it buying time. We really try to buy time and see if we can change some small factors, help with pain, promote healing, promote exercise, to see if we can get that person back and up and going. Okay,
and the exercise, basically, I would imagine it would strengthen. It would probably help with positioning. It would probably help with a lot of things as far as exercise is concerned.
Absolutely. So when a joint is affected, it affects the muscles around the joint. It can affect the other leg. We work on strengthening the muscles around the joint itself, increasing the range of motion, and helping with the swelling.
Okay, all right. What about as far as, I know a lot of people and a lot of seniors do exercise in the water or pool. Would that help this as well?
Absolutely. Anything that promotes range of motion will make a difference.
Right. All righty. What I'd like to get to just the aspect of surgery. When someone has come full circle and they've done everything they can, and you as an orthopedic surgeon actually has to go in and do surgery. Tell me a little bit about that. What are we talking about here?
Okay. What we're talking about is actually opening up the knee joint and removing the arthritis.
Right.
Okay. Oftentimes there's about this amount of bone that has to be removed in order to get rid of that arthritis.
Right.
In its place, we replace that bone and arthritic knee with a metal and plastic bearing. Okay. And that metal and plastic bearing actually allows pretty good range of motion. Okay. Now I tell a lot of my patients, the surgery takes about an hour. We're down to about an hour and 10 minutes. But the recovery is the difficult part. The physical therapy, making sure that your medical conditions are under control, the diabetes, high blood pressure, because those all play a factor in the recovery process as well.
Right. Now, recovery time. How long? I got to go to work.
Right.
When can I get back to work? How long is this going to take?
Okay, great question. Minimum of about 3 months, okay? We like our patients out of bed the day after surgery with physical therapy. So we get people up and moving right away. We have to wait for the swelling to go down, okay? The swelling takes about 2 to 3 weeks to go down. And if we put a suture in to close the skin, we typically remove that at about 2 to 3 weeks.
Right.
So those first few weeks, we want to make sure the wound is healing well.
Right.
The range of motion is improving. And then after that, we work on strengthening and comfort level going up and down stairs and getting around.
Okay. Now, is there home assistance? Usually, do you need somebody at home to help you out? Like if, your wife has to stay home? No. But you know what I mean. Those first couple days, would you need somebody to help you out?
Yes, I highly recommend it. Oftentimes what we'll do is if we do a surgery on a Monday, we'll watch the patient till about Thursday, and then typically on Thursday we'll send them to a rehabilitation facility, so that they can be monitored by physical therapists, nursing staff, and physicians.
Okay.
So their medical conditions on top of their orthopedic, their knee replacement is being monitored.
Right.
And then from there they'll transition to home. And then at home they can either have a family member help them, or sometimes a home health aide as well.
Okay, all righty. So you should return to a normal activity in about 3 months or so. You can get back to work and you can feel normal. You're walking successfully, you're upright, your knee you shouldn't be hurting, and you should be feeling normal again, huh?
Yeah, so 3 months, that's a little generous, but if all goes well, yes. I think I try to educate my patients that it takes time, and I see that people improve up to a year.
Right.
You can be back at work between 3 to 6 months, but oftentimes you'll continue to improve up to a year after surgery.
Excellent, excellent. Well, this is an interesting subject. It's just one that you can really connect with because we all are going to age.
Right.
And, if you've played football or if you've done any sports, you play tennis and you're out there and you feel a twinge in your knee and it's coming. You know that at sometime you're going to have to see an orthopedist or someone to help you out as far as the pain is concerned. I'm just so glad that you could come and you could give us a total overview as to what's going on as far as the knee and arthritis and how we can combat that.
Yeah, well, thank you. I'm so glad to be here.
Thank you very much, definitely. And we're going to have to get you back for another topic.
I can't wait.
All righty, all right. Well, it's that time in our show that we must close because we've had such a good time with Dr. Lee, but sometimes you just gotta go. So remember, sharing and caring. Remember, email me, www.medmoments.com, and tweet me @medmoments. I'd love to hear from you guys because I'm loving all of the information that you're sending my way. Never institute any change in your medical therapy before you consult your physician. I trust each and every one of you continued good health. I'm Dr. Omar Bey, and this is A Moment in Medicine. Until next time, peace to you all. All righty. Thanks. Good.
Oh, anytime. Thank
excellent,
you so much.
excellent,
Right.
excellent.
Thank you.
Just